Okay. We've got 3 people in the waiting room. I will just let them in. Just waiting for Curtis Degenfelder to make it in. Josh Snowman, Josh Pendergast, just making sure we let everybody in before we start. Okay, everybody. Good morning, happy Monday. Welcome to the second of the 2 technical assistance meetings. I think most, but not all of you were on the first one. We really don't want to have a rehashing of everything from the first one, but we did hear you on the request being more burdensome than one might hope. And so we put our thinking caps on about what can we do to make sure we have the data that we need to be able to get the SPA passed, while making it simpler. And we did come up with something. So we will share that now. So, tabs 4 and 5 are pretty straightforward, and there's really nothing that can be simplified there. It's just, tab 4 is just a data dump from your claim system of everything that you bill under Section 31 that's not a T1015. So that should be pretty straightforward. Tab 5 is everything that your tax identification number bills under other sections of policy other than Section 31. So that should be just pretty straightforward also. Nothing really burdensome there, just a dump from the claim system. Where things could get burdensome and challenging is that distinction between tab 2 and 3. Where tab 2, both of those tabs are intended to get what you're billing under the T1015. But tab 2 versus 3, we made that distinction between what's in the Medicare statute. And we think that's probably where this would get really burdensome. Like you guys trying to figure out, well, how do we parse this out? Like we can do a big data dump of what we build under the T1015, but how do we parse it out between these 2 tabs? It's just, there's not, the federal statute says one thing, but then when you know what you bill under the G0146 to Medicare, it says another. So our solution is let's just forget about that distinction between tab 2 and tab 3, because that's really the confusing, onerous part. And so the revised instruction, and we won't send out a new template because, you've already got the template, but basically just sort of just tab 3, just forget about it. And we can send that in writing afterwards. It would just be put all of your T1015, everything you bill under the T1015 on tab 2. And so that way it is simply a data dump from your claim system. And then we will figure out what parsing out, if any, is necessary between those 2 tabs, which we would then share with you. But this will hopefully make the request at the front end for you guys a lot simpler, because all this will be is creating data dumps from your claim system. So I will pause there for questions and comments and reactions, because again, we really don't want this to be some burdensome thing. It's really just about making sure we get the data that we need to make sure that we can get the SPA passed by CMS and get that 3/31 effective date. So any questions, comments? And then again, and then remember, this is a technical assistance session. So, if your staff has questions about, how do we create these data dumps? I mean, granted, everybody has different systems, but we can, Guidehouse can do everything it can to assist with TA on how to create those data dumps.
Hi, Peter. It's Chris Duty up in Northern Maine.
Hey, Chris.
How are you?
Good, thanks. How are you?
Good. It's been a while. So when the hospitals went through this exact exercise, the rebasing, I mean, we have a methodology that was used in the last, 2 to 3 years. Is it the same process or is it something different? Because it didn't seem like it was this cumbersome.
Are you talking about the rural health clinics when you say the hospitals?
Yeah.
Good question. I wasn't in this role back then.
Okay.
The other thing is, I don't know what we're doing now, the approach that we're taking is in direct response to feedback we've gotten from CMS. So about needing to be very clear about what costs are built into the T1015, and having, what services are built into the T1015, and making sure that that's applied consistently across all FQHCs. They've just been really clear with us that needs to be cleaned up. I mean, for several years, they've been telling us this, and we knew that next time we have to open up the state plan, it's not, whatever it's for, it's not going to be passed unless we address these questions, these issues. So whether there were similar issues with RHCs that would have necessitated a similar approach, I just don't know, because I wasn't around. All I can say is that, CMS has been very specific about FQHCs.
Hi, Peter. This is Kurt Eggenfelder. I'm a consultant that's been retained by the PCA. I was curious on I guess we're now focusing on worksheet 2, the columns F and I, which are looking at costs for these other services, or I guess you're looking for kind of costs broken down by type of code or type of provider. What sort of methodology are you looking for, or what sort of backup are you looking for in order to inform the completion of those columns?
Okay, and this is I'll answer the question. This is, just so everybody is aware, this is all written up in the statement of intent document and sort of the explanation. So folks do have it in writing. But so just to take those questions one by one. So first, don't worry about provider type. So the sort of the new instruction about, tab 2 was for certain types of providers and tab 3 is for other types of providers. So don't worry about provider type anymore. So basically every row on there on tab 2 is just going to be a procedure code. It's going to be one of the procedure codes that was billed under the T1015 and that pays at 0. Section 31 is very clear, and last I checked a few years ago in claims, FQHCs were doing a great job complying that when you build a T1015, that's where we pay on that at your encounter rate, but on the claim lines below the T1015, you put the actual procedure codes that you do, the HCPCS and the E&Ms and so on and so forth. So every row on that sheet will correspond to a HCPCS or an E&M or CPT. And you will put the number of units that you would build. And then you would put the gross charges. So from your charge master. And as we discussed the other day, the reason that we're asking for that is the quickest way to impute the costs associated with those services, so that in the event that, per the back and forth with CMS, some services need to be moved from the T1015 out of the T1015, or the other direction, moving something from tab 4 or 5 into the T1015, we need to know the costs to be able to build that into the rate. And the quickest way to impute the costs associated with that particular service is by applying the FQHC's overall cost to charge ratio to the actual charges that you had submitted. Now, if the FQHC has its own cost allocation method that's different, so that it has something a more granular way to go about of saying, oh, the costs associated, with these 1,000 units of, whatever service were X, you can put that in. But we were anticipating that, because, large hospitals have such complex cost allocation software and such because they're bigger. But we were anticipating that FQHCs, being a lot smaller, likely don't have a cost allocation method like that. And so sort of the best proxy would be using that cost to charge ratio, which we would do for you. But if you have your own cost allocation method to put the costs associated with that line, by all means do. Does that answer the questions, Kurt?
It's helpful. I'm developing a picture now. So you're going to populate that last column by looking at the total charges and looking at the total costs, and then develop a cost to charge ratio and apply it to each of the charges. All right. So I guess my concern would be, and I apologize, I'm coming in a little late in the game. Sometimes health centers don't charge for each individual code in correspondence with their costs. So they might charge less for a certain service. They might, and we're talking about gross charges here, right? Not after contractual allowances or after the health center sliding fee, right?
Correct.
So sometimes they might charge less for certain codes for certain policy reasons. So how you want them to note that on this sheet, or what are you anticipating?
Gosh, if you want, and of course that's always going to be the case. The cost to charge ratio, at the overall level, it's understood that each individual line is not going to, in reality, isn't going to correspond exactly to that. And that, it is an approximation to apply. So that's understood. If there's something that really rises to the level where you want us to make note that, this particular code, you think it's a real significant departure in terms of its ratio of cost to charges from the overall, feel free to put a note, just the cells aren't locked. So, feel free to just sort of put in a notes column. And know if there's something you want us to note, we can take it into consideration. Guidehouse team, does that seem, it's a little bit of a slippery slope, if we were to start exempting certain, rows from that approach. But I think we should see what we get from the health centers.
Yeah, let me ask my follow-up question before you kind of answer that, which is, so the reimbursement is visit based, right? So if you have, let's pick 99213, right? And you have that being performed by kind of a Medicaid reimbursed and a non-Medicaid reimbursed provider, how are you going to distinguish between those two? And here I'm arguing for more complication, which I know is not what anyone wants. So I just wanted to kind of clarify, the codes are not service specific, right? The codes are procedure specific.
Well, first, were you mentioning, Kurt? First, this is really about cost rather than revenue. So if the same service is being provided, you know, to a Medicaid member as opposed to a Medicare or a private pay. So we're really, you know, the charge master would have brought in the same charge for all three of those visits, regardless of who the member is.
Agreed. What I'm asking is, I assume, and maybe I'm wrong in this assumption, I assume that you're using this methodology to capture a total bolus of allowable cost, right? And so if we have that 99213 line, how will we know which of the costs are allowable and which are not?
Oh
For
gosh, so you
which of
mean-
those visits?
well, unless I'm missing something, all of the costs associated with those 99213s are going to be allowable. So, I mean, within a 99213, yeah, I mean, you know, the costs associated with it are, you know, the providers who are doing it, you know, the floor space, the overhead. It's basically, I mean, I don't think within a certain procedure code, there's any need to parse out costs between allowable and non-allowable. I think the assumption is that everything associated with a 99213 is allowable. And so
Yeah.
therefore, go ahead.
Yeah, no, I guess my concern is when it is allowable, I would agree with your concept that it is always allowable. I guess if there are certain things where we are using any of these codes, and sometimes they are an allowable cost or reimbursable directly under Medicaid, you know, we're using the same code. So I'm just trying to picture how we would carve this out.
Oh, do you mean that there might be an occasion where the tax ID is billing a 99213 under a section of policy under other than section 31?
So I don't know your language exactly, but I'll say that we may be using a 99213 for a service that is not covered or reimbursable by Medicaid under the FQHC PPS rate. Yes.
Okay, yeah, we're saying the same thing. Can
Okay.
you think of any example? Can anybody on the call think of an example when that might occur? I mean, because I mean that section 99213, I mean section 92, the code 99213. I mean, that would be billable under section 90, which is our physicians section of policy. And an FQHC's encounter rate is just going to be so much more favorable than the section 90 rate. I can't think of any. I can't think of any circumstances under which an FQHC would want or need to bill it under 90 instead of under 31.
Yeah, let me try to do a little more research and hold that question in abeyance just to get some actual data. Maybe it's more likely on, let's say, mental health codes or something else where we may be, because this is, if I'm not mistaken, this is meant to be supplemental to the Medicare cost report, right?
That's correct.
Okay,
Yeah,
so we're going to be getting dental, right? So that's one of the things we'll be capturing, all those CDT codes, right, to bring that cost in.
that's right. That's exactly right. And something that you just said, the sentence has already left my mind, but it was really key. That yeah, I mean, this is all about, I mean, so just that general question of, are there any instances when an FQHC might want to bill something not under their T1015? I mean, that's the thing that CMS is really requiring that we be super clear about. Like, what are the things where that's, you know, they want us to get rid of any ambiguity there. They want us to be really clear about, these are the things that are in, these are the things that are out. And then once that's been established, making sure that it is implemented uniformly across all FQHCs. And that's really why we're going to have these. It's no longer 4 tabs, but it's the 3 tabs. Tabs 2, 4, and 5, just to be super clear about that. So as things stand now, I mean, it is our full intent to get this implemented for 3-1. So that come 3-1, you're submitting claims and they're paying at these rebase rates. And in order to meet that deadline, we had set the December 16th deadline for getting the data back from you. So that is a week from this coming Friday. So basically it gives everybody, two solid business weeks, 10 business days. So do folks feel like that sort of reprieve on having to separate out the tab 2 versus tab 3 so that it's just a big data dump, makes this easier, addresses some of those, well, how do we do this question? And I mean, and this is, again, this is a technical assistance session. So ideally, if folks have questions about, some mechanical stuff, data dumping, it's really those 3 fields: procedure code, units of service, and then gross charges associated with that, with each procedure code. And then just throwing that onto those 3 tabs. Do folks have questions?
Hi there, I have a question. It's Janka Adams.
Okay, Jenka.
I am curious about how we have the FQHC PPS codes listed on this sheet here for FQHC procedure codes. So namely G0466 through G0470. Those are basically the Medicare equivalent of your T code, but have a fee assigned. And so in reporting those, we may be inflating our charges. I want to ensure that that is what you want us to include in the count. So for example, if we build Medicare for a new patient 99203, we are going to have G0466 and 99203 on the claim. So you want us to be reporting both of those on tab 2, is that correct?
Let's just think, David, let's put on our thinking caps and see how that would be reported. I mean, we definitely want the visit. In terms of, how would reporting charges?
I'm just trying to understand what, the statement that was made that you'd be grossing up charges or something to that effect. I'm just trying to understand that.
Yeah. So for main care, T1015 is not reported with a fee, right? It's kind of lumping all your CPT codes together. Whereas with Medicare, you are placing a fee on G0466, for example, to represent what your average cost for the Medicare beneficiary would be, in addition to your usual and customary code for the service actually rendered. So for example, in that new patient scenario with the 99203, we could report G0466 at $300 with a 99203 at an additional $300. So that one new patient visit would represent $600.
So let me sort of play that back to you, and this is, thank you very much for the question. So let me just see. So I guess let me how I've been thinking about this, and then when we built this, is that since the T1015 represents is a bundle, right? It's a range of things. It's a lot of things that can be under it, and so everything that when you submit to main care to be reimbursed at your PPS rate, the T1015, there's a range of services that that come under that. And as Peter had said earlier, you know, the FQHCs have been doing a great job of submitting those in. There's zero paid, but they'd still have charges on them, right? Because they all roll up to that T1015 PPS reimbursement rate. But all the lines, all that detail is there on the claim with your charges, with your units, with everything. It's just, as I say, it comes out zero paid. So but you're saying is when you bill Medicare, you bill a G0461 and you put in and you know, and then you also bill an E&M code under that. So you bill two codes. And the example you gave, both have a $300 charge, so it'd be $600 in charges.
So let me paint a picture of Medicare versus main care. So for that same example, right, $600 to Medicare. If I was to report that exact same claim to main care, my gross charges would be $300.
Right, because you'd be billing. Right, because you'd be billing for the E&M.
Correct.
Right, so that's what we'd expect to see on the cost report is, you know, that E&M times the number of units times our charge rate for that $300 if that's the case, and then the total charges for those E&Ms. Does that make sense? I mean, because I think
it does, but what I'm confused on, I understand reporting the E&Ms on tab 2. What I'm confused about is additionally reporting the FQHC specific PPS codes on tab 2 when they are related to the E&M codes of tab 2.
Right. And so for main care, I mean, so does your charge master have a charge of 0 for T1015?
It does, yep.
Okay, and your charge master has $300, just using that example, for the G0146.
G0466, yes, correct.
Oh, sorry. Well, then it seems that David, it seems that we'd have two options. One would be that we could just zero out that charge on the G0466, you know, because we know that, as Jenka said, it would inflate the charge because it's double counting. Or we could just factor in the fact that, or if we don't do that, everybody's cost to charge ratio, or I guess everybody's charge to cost ratio is going to be higher if we, you know, and so it would, I think it would come out in the wash either way. Like either way, we would get to the same cost, because that's all. The only reason that we're asking for charges is to be able to do cost at the line level by applying the overall cost to charge ratio to each row.
But your costs would actually be lower if you're including more charges. So that would definitely hurt all organizations.
Well, the costs are the costs, because we're going to be taking those straight from your Medicare cost report, because we know what the costs are going to be. So the costs aren't going to change regardless of what the cost to charge ratio is. But actually, the more we talk about this, each individual row would end up having a lower cost if we counted the G0466 as a $300 charge. So having said that, just having talked that through, I think that the fix is to zero out the G0466 charge, precisely for the reason that you just mentioned, Lori, because every row would end up, the cost would still total up to the total cost on the cost report, but the cost of each individual row would be lower if we don't zero out the G0466.
Correct. There's also other G codes too. There's a 67, 68.
Yep. So because Medicare requires that you bill that way, in a way where the charge gets duplicated, I think we should. I mean, that just raises the question: do we want the FQHCs to zero it out on their end, or do we want to zero out for them? David and Guidehouse team, which do you think is the cleaner, more efficient way?
Well, I want to ensure that we are consistent across the board, because when we assimilate the data, we'll do it, we're not going to do it by facility, we'll do it en masse. So my sense would be that regardless of what's there, we'll zero it out, across the board. So do as you may, whatever you started to do already, and we're just going to zero out the charges and costs and units for that code.
And actually, yeah, that's also consistent with the idea of us trying to make it less burdensome for you, because it means we could do it for you rather than, and that takes out a step on your end. So it's just, so you guys just do the claims dump. You don't have to do any manual manipulation of it. We'll do that for you.
That's right. We'll clean it up. The key thing we're looking for is consistency. Is you all sort of do the same thing per the instructions that were provided. But we're going to do on our end, we're going to be doing some cleanup, and if we have any questions about what we're seeing, well, we're going to absolutely engage back with you and say, this is what we're seeing. Make sure that's correct. What's important is that we get, the information is complete and it's timely, right? Just want to sort of stress those two things. But as Peter said, the goal is to make this as simple as possible for you all, because you all we know are doing a lot of good work.
So on that same vein, then I guess I would ask, do you really need the description of the CPT code column?
We just need the CPT number.
Okay, great.
Okay, yeah, we can just find some file and just bring it in.
No, we can do that.
Bring in the descriptions. Franco.
Yeah, just do you guys have the G codes that we're talking about as a list? So like we're talking about the 466 through 470 and some other codes. Do you have that list so that we're all on the same page essentially? And that would be agreed to as a key element, that these codes would not be reported. I just want to make sure we have the same list across systems here.
I think that's a great idea, Franco. And I was, I was going to work with Guidehouse offline to come up with a list, and then we would send it to you guys, the collective view, to say, hey, we're all on the same page about this. If somebody from MPCA or the FQHCs wants to send us the list as the initial starting place, I mean, that's fine too, either way. Does anyone have a preference as to whether we generate the initial list and send it to you all, or whether somebody on your end does it and sends it to us?
I know that I'll have Jenka Adams send you the list.
Okay, great.
On my side.
I was sort of sitting on, I nominate Jenka, just on the past few calls I've had with her. Jenka seems very on the ball. And steps up. So that's great. So gosh, Jenka, when you send that, if you could just reply all to the meeting invite, that way everybody who's on this call will get it, and we can just make sure everybody's on the same page. Now, Franco, you mentioned omitting those G codes from the data dump. That's not, I mean, we could do that, but that's not what we just said we would do. We said, let's include them on there, but then we will zero out the charges to avoid duplication. Personally, I think that's a better way to go, because each G code is a discrete visit. And so, we'll sort of ensure that we've got the correct visit counts. Do folks agree with that?
Yeah. That sounds right, Peter.
FQHCs? Okay, well, hearing no objections, we'll take that as agreement.
Hey, Peter, it's Kurt again. Can I ask just another question? I'm kind of thinking this process through. Um, so in lieu of using, since we're going to ask for all the services and costs, we're going to be getting a cost for each CPT code. And then we're going to get a count of visits, and we're going to divide that cost by those visits and come up with a rate, or what is the methodology? I'm trying to see
Yep.
to the end of this.
I mean, basically, I mean, at its simplest, it's exactly, you know, to Chris's having mentioned at the top of the call what the process was for the rural health clinics a few years ago. You know, at its simplest, it is simply taking total costs and dividing it by total visits. That's all this is. That's, you know, that's what BIPA required. And even though we're doing a quote unquote APM, a BIPA APM, using the 1999 expression of what APM meant under BIPA rather than what we all think about it means today. Yeah, it's still the same thing. We're taking the 2000, you know, the 2018-19, 2019 costs, and we're dividing it by the 2018-2019 visits, and then we're making the appropriate inflationary adjustments to those costs. Just the only reason that this gets a little weird and squirrely in terms of, I mean, and it's not weird and squirrely, but the distinction between, you know, all this sort of nuance about service code level, it all comes back to that stuff that CMS has told us about. Maine, you need clarity about what is in versus out of the T1015. And that is the reason that we're asking for this stuff at the code level, because in the event that there's something that we all decide to move in to the T1015, so just by way of example, like let's say that we collectively decide that vaccine administration should be moved in instead of being paid as a separate fee-for-service rate, we need to have the costs at the service level precisely so that we can move those costs and visits in. Or in the event that for some reason that there's something where we collectively decide, oh, this should not be included. And I don't know what that might be. There might not be a single thing. It might just be only moving a few stray things that are in the chapter 3 into the T1015. You know, or it might be something, you know, around what was it? You know, the fillings and the dental lab. You know, is that something where where that should be kept separate and outside the T1015? Or is it something where, hey, let's identify what labs are charging you when they create those, you know, amalgams or, you know, whatever, you know, that expensive stuff for the teeth. And, you know, that could be potentially moved into the T1015. And so the only reason we're asking for that data at the code level is for those marginal, maybe moving a few things in or out. And once we know that, it's just dividing those costs by the associated visits.
Okay. So then one of the things that we need some diligence on, since visits, right, of what's a billable visit already established, that there may not be instances where there is something that is represented with a visit code, but is not in fact another visit. We don't want to make the denominator of visits too large because the health centers are going to be getting paid on a per visit basis, correct?
Correct. You do want to be careful on your visits. I mean, and that will be easy with the T1015 and the G0146. I don't know how you guys track things for privates and for self-pay, but just same thing. You know, I mean, yeah, you know that with MaineCare, if you're billing three different, you know, an E&M and you know, something else on the same visit, and it's a T1015, you know, you have your 2 rows, but we need, ultimately our count of visits on tab 2 is going to be the total of the visits of the T1015s and the the Medicare encounters. And making sure that we're not double counting any private pay visits. So
Yeah.
on tab 2,
Yeah, I
that's,
think you're right. Yeah, typically those are not billed with T1015. So those are billed again with your E&M codes. If they're mental health, there are codes. With dental, there are certain that represent visits and certain that represent individual procedures. So I think we need to come on agreement with which of those codes are visits and which are additional procedures. And then is there any nuance to that?
that's a great point, Kurt. And yeah, I mean, if you guys, yeah, we're just so used to on the main care side. And also, knowing how it's pretty, simple to count the visits on the main care side for precisely that reason, because it's only the T1015 that shows up as the visit. And then same would be true with Medicare. But yeah, on private, that'll be good to get your feedback on what you think is the best way to do it. And then another thing just about the process for all this. I mean, this is precisely why we wanted to get that deadline for getting the data back from folks, good and early. December 16th, gives Guidehouse, a week to begin working with it before the holidays. Then, that week after December 23rd, just a lot of people, it's hard to get a lot of work done. But January, we wanted to leave time for questions, as Guidehouse goes through the data. I agree with you, Kurt. It's preferable that at the front end, everybody agrees on how we do private and make sure that there's no double counting. And I mean, we have 15 minutes left right now. If we've got the right folks on the phone to really brainstorm on that and reach consensus, then that would be awesome. If we're not able to do it by the end of this call, I would suggest that we do it through email with a goal of reaching consensus in the next day or so that folks have time. But this is a great point that you've brought up about, that privates do it differently. So I want to get to Michelle's question, Michelle Eastman, but Kurt, I mean, what do you think? Does that, or what is?
Yeah, I agree. We'll try to get up front, but until you have the data in hand, I mean, really what I would love to see is a chance for us to review the rates. I don't know if they're going live in March, but hopefully we're not going to get them on February 28th and say, hey, tomorrow you're going to get paid at that rate, that we would be able to track through the methodology. Because it's harder to envision on an empty template versus looking at, you've gone through the process, you've calculated the rate, here is the rate, right? And we can compare that to our current rate and doing a gross, just current dividing our total cost divided by our total visits. So until you see how it comes out, I guess my question would be, what's the timing for review and discussion on the back end post calculation?
Yep, you will have that opportunity to review. The exact timing we haven't worked out yet because we don't know exactly how long it's going to, once we get the data, we don't, we have to see what we get before we know, how long it's going to take us to come up with the rates. But there's a new section of Maine law that was enacted this past spring and summer called Chapter 639. Even though we're doing this rebasing pursuant to the law that that's governing the rebasing itself, we are also complying with the procedures in Chapter 639, which require that we share the rates. We publicly present them and give you an opportunity to comment. So, I mean, in terms of timing, if things go really fast, possibly mid-January, we could have rates out to you for review. Along with, you know, the data sort of showing, you know, here's where those costs came from, here's where those visits came from, because your rate is ultimately, you know, just the quotient of those two.
And the one thing I want to add, Peter, and I know, you know, this session and the one we had before, and with the great questions we're getting and the questions we've gotten has been super instrumental for everyone, and hopefully people will be able to do it. I just want to emphasize that the sort of the better and the cleaner the data, the faster we will be able to get rates out. In other words, the more time we spend cleaning and getting back, it'll just take, you know, so, and we know, by the way, that we know everyone is putting their best foot forward and doing this and really wants to be, you know, collaborate, and we appreciate that. But just it goes without saying that the cleaner the data, the faster the response will be. But we know you do that anyway. I just, you know.
Michelle.
Hi, I just had a clarification on the spreadsheet because it says total cost should have only included if there's methodology. So you're taking our 2018 and 2019 cost report, cost per visit in this calculation, or our total cost. But like, say we have LCPCs, LMSWs that had to be excluded from our Medicare cost into different sections and our dental. Should those be the only lines that we're putting costs in on this spreadsheet for, like, you know, counseling 90834 or the D codes?
So Michelle, do you have a cost allocation method internally that would allow you to enter what the costs are using something other than just applying the cost to charge ratio?
Yes, but yes, I do.
Okay, then I would say, I mean, David, just that whatever their, you know,
I would put
whatever
it
it is. But ultimately, I mean, because the CMS cost report, because the 224, I mean, it identifies what's a Medicare allowable cost, and it also identifies Medicare non-allowable. So the sum of those two things from your 224, when we add up everything from that column on our supplemental cost report, it should equal the sum of the Medicare and the Medicare allowable and non-allowable from your 224.
Okay, thank you. I wasn't sure you were taking the unallowable as well. So
Yep, because
that
those
seems
are,
standard.
yeah, because those will be, you know, allowable under Medicaid. And so we need to make sure that we're counting those costs and we're counting those visits. And this all gets back to sort of like how we're tying out these three data sources, just to make sure that, you know, we've got our supplemental cost report, we've got your Medicare 224, and then we've got your audited financials. And basically, we're just making sure that, you know, when we're taking those three things, you know, the costs, I mean, they're not going to tie out to the dollar, but you know, if there's a variance that causes an eyebrow raise, then it's just, you know, Guidehouse can get back to you and say, you know, how come over here the total costs were 10 million and over here they were 11? What accounts for that 10% difference? And there might be a legitimate, well, there, you know, there's probably a legitimate explanation, but we just want to make sure that we're using the right thing.
Hey, it's Kurt again. A quick question. Which column from the Medicare cost report are you using for cost?
Oh gosh, we'd have to open one up.
Okay.
I don't know. We don't know. I don't know offhand which one.
Okay, because I believe there is one, and I don't know offhand either. I believe it is column 3 ties to the audit. So I assume before Medicare does any of its stuff, you would want just the straight up cost. Yeah, I believe it's column 3 is called net expenses.
Mm-hmm.
Net as opposed to gross?
It's a Medicare term. I don't know where they.
I think column 3 says total cost. Column 7 says net expenses.
Oh, column 3. Okay, thank you.
Okay, and if you guys wanna, I mean, just like with the, gosh, I'll take it, let me create a to-do list. So the one item was, Jenka was gonna send, what was Jenka gonna send?
G codes.
Okay, list of G codes. Is there anybody that wants to send us, here is the FQHC's guidance on which column from, I mean, again, we could do it on our end and send it to you. This is all just about, making sure that somebody sends it to somebody to make sure we're all on the same page about what's being used.
I think the health centers should have the ability to be able to recommend a column.
Okay. Darcy or Sharon, it would probably be a good idea if we just establish a date by which you will send that to us.
Peter, this is Darcy. Just so you know, Sharon is out on medical leave. So I have a follow-up conversation at a board meeting tomorrow. And so based on that conversation, I might be able to get you a recommendation, but definitely in the next couple of days.
Okay, thanks very much.
And sorry, when I say column, I mean both worksheet and column, so.
Okay.
This is Lori. Can I just make a clarifying statement? In the guidance, the statement of intent, it refers to total costs and total visits. However, on the spreadsheet, it's asking for total volume in units. I just want to make sure that we're not interchangeably using those two terms because they have a very different financial impact. If we're putting total units, it's not anywhere near the same as a total visit cost or charge. Dental could have 5 charges, 5 units, 1 visit. So I just want to clarify, you are asking for units.
At the CPT, or in that case, DPT level, right? In
Yes.
other words, I mean,
Okay.
you're correct. I mean, a visit could have a number of things charged to that visit, but each of them are at the procedure code line level. So that's
Right.
Yeah.
Right. I would just say that perhaps the statement of intent just needs a correction. Instead of saying total visits, it's total units.
Well, when we do the calculation of the rate, it's visits. Otherwise the rate would end up way too low if we're just using the units that made up those visits. But this gets at what we were talking about earlier, where that's why you should be including the T1015 number of units, because that is the visit, that gives us the visit count. And why, even though and then with the Medicare encounters, same thing. You would tell us the number of G0466s, because that is the visit count that we're going to use, but we're going to zero out the charges to make sure that charges aren't being double counted. And so then with private, it just becomes, everybody needs to be really careful that, if 3 different services were provided in the same visit, this needs to be documented in a way like it is for Medicare and Medicaid that make clear that yes, there were 3 units in 1 visit. So we just need that to be clean in the data. Does that make sense, Lori?
Well, yes and no. I mean, that's nearly impossible to do at the CPT code level.
Well, it really, it gets back to what's the best way to do it for private? Because Medicare and Medicaid, it's not an issue because there is that encounter code that makes everything very clean and easy. But
so then what you're saying is on the template, we're going to put T1015, total charges, total visits.
Yes.
So then we wouldn't want to exclude the G codes because we would need to put the G codes for Medicare, total G code charges, total visits.
That's
And then
correct.
somehow come up with a methodology on private to not report at the CPT code level, or to somehow combine all the individual CPT codes into a visit line item.
Oh gosh, okay. Okay, TA and brainstorming. 2 minutes left in the call. Gosh, when the date of service is the same, I mean, yeah, we certainly don't want member info from you. We do not want, so how, I mean, the way to figure out, like, it, so how to do this so that it's not a burden for you guys. I mean, in the ideal world where we had all the time in the world, it would just be, hey, Peter Kraut had 4 services on December 5th, because all 4 services were for Peter Kraut, that is probably 1 visit. But if you're not including member info, well, there's no way to do that, because there could have been lots of different individuals accounting for those visits on the 5th. So yeah, if you did that at your end with that member level, patient level info, you would be able to do that, but we don't want to put a burden on you to do that. So, gosh, does anybody else have any other ideas on the most efficient way to, for the privates, make sure that we can get to visits?
But when you're including all the x-rays and stuff that we're doing on top of, a patient 1, patient 2, but maybe I'm not doing x-rays on patient 3, when we're giving you those 7,000 codes or the different codes that may or may not be included, aren't we lowering our cost per visit?
No, you're not.
Okay.
Because ultimately, our goal is, the denominator will be visits. It's not going to be the volume of CPT codes, right? Because that would not be the right denominator. We want to be using their number of visits. So I think this has been an excellent conversation. What we can do is take it back and provide sort of clarity on how we are going to take the data, accumulate it, and parse it, and then compute the rate based on total costs and actual visits. I don't think we can sort of arrive at that point or share that at the moment, but we can share that back to you relatively shortly.
If I could throw something in our last minute, I believe that every health center is probably counting visits because they're really focused on provider productivity and that sort of thing. So I'm just going to throw this out here, rather than, if we already have a visit number, rather than making the state calculate it, if you want to use it for the costs and the health centers give you their visit number, this issue has already been dealt with around which codes are visits and which codes are not. So if you wanted that, I mean, personally, and I have not cleared this with any health centers, but I think this is a reasonable ask to say, give me your visits that you've recorded for those 2 periods.
Curtis, that's a very interesting thought. I appreciate that suggestion. Maybe, and that's something we may take you up on. So I think let us take all this back.
We'll email you back.
These have been great questions, and a good discussion. I do see we're at time, but we do want to thank you all.
To Darcy's question, I will send I'm going to do next steps rather than, detailed minutes, because it's, the next steps really move the ball down the road. And yeah, we will brainstorm, because this, what we were just talking about, really just gets to the, on the privates. And so we'll brainstorm and we'll send out an email, taking into consideration what you just suggested, Kurt. And yeah, let's just all get on the same page through email.
And I just want to throw out one last comment. It might make sense to put all your Medicare and Medicaid payers on tab 2, and maybe put your commercial payers on tab 3.
That's a neat idea. Okay. Yeah, and I mean, we were thinking we don't want to send out a revised template. especially if folks have already started. But that is an intriguing idea, Lori, that, just to keep things clean and separate.
That way, if you have questions going forward, that it would at least be segregated.
Yeah, I like that idea. Have folks already sort of started filling it out, and would it be create a new mess if we sent out a revised template? Just basically, and the only revision would be saying what Lori just said. Tab 2 is all T1015s and Medicare encounter. And then tab 3 is all private. You know what, we'll do that through the email also, because we really are at time. So everybody, thank you very much for what I thought was an extremely, extremely productive call. And we'll keep on moving the ball down the field. Okay, thank you, everyone. Anything else before we break? Anybody? Hold on, somebody else made a chat. We will share the recording. Yep. We have the recording of this too.
Thanks all. We appreciate all your feedback.
Thanks, everyone.